about kidney recipients and some conclusions about related living donors. Starting with a kidney transplant recipient. In 1956, Edith received a graft from her identical twin among the first cases transplanted by the late Professor Joseph Murray. 2 years later, she became the first kidney transplant lady with a successful pregnancy, and Professor Murray reported her among a small series of successful pregnancy after transplantation a few years later. Nowadays, thousands of successful pregnancy among kidney transplant ladies are being reported all over the world. Despite that, the rate of pregnancy among kidney transplant recipients might be less than general population, yet it is well known that fertility dramatically and rapidly improves after transplantation. And therefore, counseling about family planning is very important before transplantation and during transplantation. The question is which contraception we can use for such patients. These two authorities recommend the use of contraceptive pills, provided that blood pressure is controlled, alarming or even contraindicating the use of IUDs, either for fear of non-efficacy or infection in immune-suppressed patients. However, Centers for Disease Control and Prevention, CDC, have a little bit different words. In uncomplicated solid organ transplant ladies, CDC considers all forms of contraception equal, in that the benefit of their use outweigh possible risks. However, in complicated solid organ transplantation by, for example, rejection, the use of combined oral contraception becomes unacceptable, while progestin-only pills or continuation on IUD is still accepted. More and more reports about successful use of IUD among transplant ladies led some authorities to consider IUD the best, perhaps the best contraceptive option because of its long-acting and reversible effect. Also, there is room for local causes, despite less effective because of very high safety. So I think it is rational to state that contraception advice should be similar to the general population and that it should be tailored according to every patient, waiting for more data to have more clear guidelines. Now, who among our patients I can allow for pregnancy? KDIGO guideline suggests to wait for at least 1 year after transplantation, provided that graft function is stable and proteinuria is less than 1 gram per day. The American Society of Transplantation emphasizes on the same guidelines with even more strict upper limit of proteinuria and add some other prerequisites. No rejection in the past year, no acute infection that might impact fetus like CMV, stable dosing of immune suppression, and no teratogenic medication. Some other prerequisites, although from some older guidelines, but I think still reasonably working: normal graft ultrasound and no or controlled hypertension. The American Society of Transplantation states that whenever we would like to go outside its guidelines, this should be on a case-by-case basis. What are potential complications for this pregnancy? Let's first agree on that this type of pregnancy is a high-risk one, necessitating careful, meticulous, combined nephrology and expert obstetric follow-up. There are a number of potential complications on both maternal side and fetal side. Perhaps the most feared complication for the mother is graft function deterioration. Risk factors for graft deterioration are almost same like pregnant ladies with chronic kidney disease without transplantation, namely baseline renal function and hypertension. Whenever these factors are okay, usually renal outcome will be like kidney transplant outcome without pregnancy. When there is graft dysfunction during the pregnancy, besides rejection, there are a number of differential diagnoses related to pregnancy itself: UTI, graft obstruction, and severe preeclampsia. We have to prevent graft rejection by careful pre-transplant planning for safe and effective immunosuppression, maintaining this immunosuppression throughout pregnancy, and very importantly, doing careful drug monitoring. Even though if graft rejection happens, still there is a room for biopsy and standard treatment. Long-term graft outcome, same like short-term outcome, largely dependent on baseline pre-pregnancy graft function. When early graft outcome is okay, usually pregnancy does not affect long-term graft or patient survival. Apart from graft dysfunction, other maternal comorbidities might happen due to pregnancy. For example, hypertension occurs in high frequency, and contrary to non-transplant pregnant ladies, hypertension in kidney transplant rejection in kidney transplant ladies must be early and carefully, aggressively treated. Diabetes, either new diabetes or gestational diabetes or aggravation of already present diabetes, and infection. Very high prevalence of infection in pregnant kidney transplant ladies, about 20%. The most common is the urinary tract infection. CMV is very important for the fetus. This necessitates prenatal screening, vaccination for hepatitis B if the mother hasn't received it yet, and continuation of screening throughout pregnancy. For example, urine analysis, culture, CMV, toxoplasma for those ladies who are naive for that infection. And if infection, serious infection happens, it is always helpful to have the help of IDT. Anemia also is common, especially during the last trimester. The overall pregnancy outcome again depends on the same factors: baseline renal function and hypertension. There are a number of other complications that might happen for kidney transplant pregnant ladies. This is a meta-analysis involving about 5,000 pregnancies and 3,500 kidney transplant recipients. Here we can find that preeclampsia, gestational diabetes, cesarean section, and preterm labor were significantly higher among kidney transplant pregnant ladies compared to the general population. The same meta-analysis found that studies with lower mean maternal age had the best outcome. On the other side, studies with short transplantation pregnancy interval had the worst outcome. What about fetus? CMV infection is horrible for the fetus, many disabilities. However, there is some assurance from the National Transplantation Pregnancy Registry. This is a huge North American registry for pregnancy among the transplant ladies. In its latest report, involving about 2,000 pregnant outcome, mostly from kidney transplant recipients, there was outstanding successful rate of pregnancy. And more importantly, birth defects were almost same like general population, except for ladies who were receiving microfluidic mofetil. And nicely, also long-term follow-up regarding development of this offspring is also reassuring, nearly similar to the general population. This is an experience from Mansoura, Egypt, although a little bit old, being updated now. About 15-year experience for 67 pregnancies with high prevalence of graft dysfunction, though there was no rejection. What about drugs? Although FDA classifies most immunosuppressants as class C or D, most immunosuppressive medications are relatively safe with no increase in birth defects, including steroids, azathioprine, and calcineurin inhibitor. Calcineurin inhibitors are associated with increase of prematurity, low birth weight, miscarriage, and preeclampsia. But again, no increase in birth defect, same like general population. Remember to monitor drug level. It is subjected to decrease during the first trimester because of morning sickness and vomiting, and during the third trimester because of increased fetal metabolism. The case is not the same for MMF. Very worrying animal studies. NTPR reports increased prevalence of spontaneous abortion, and about 1/4 of ladies had birth defects in their babies. Again, although FDA classifies CellCept in the same category like azathioprine, yet MMF is contraindicated in pregnancy. The same is for mTOR, limited data, a bit assuring animal studies, no birth defects in human studies. However, still mTOR is also contraindicated despite being in the same category of calcineurin inhibitors. Both CellCept, MMF, and mTOR should be stopped at least 6 weeks before pregnancy. KDIGO guidelines recommends for stopping MMF before pregnancy and suggests for discontinuation of mTOR before pregnancy. Which type of delivery? Not all patients should have cesarean section, except if there is strict obstetric indication. What about postpartum period? We shouldn't forget postpartum depression, restarting contraception when appropriate, monitoring drug level and graft function, which will be subjected to change due to change in immunity, change in drug level, and non-compliance due to focusing of the mother on her baby. What about breastfeeding? Although most physicians advise against breastfeeding, this is not absolutely contraindicated. The American Academy of Pediatrics encourages breastfeeding for mothers receiving steroids and not for those who are receiving calcineurin inhibitor. More studies are needed, and breastfeeding need not be seen as absolutely contraindicated, and KDIGO guidelines advises to counsel patients regarding risks and benefits of breastfeeding. What about living donors? 2 big studies, one from Norway showing that pre-donation results were nearly similar to post-donation results, except for pre-eclampsia, which was higher in post-donation pregnancy. However, another big study from Professor Hassan Ibrahim from the USA shows that there is a multiple fetal and maternal complications which are significantly higher in post-donation pregnancy compared to pre-donation pregnancy, although are still same like general population. Just Professor Sabi was talking about that. The recent European renal best practice recommends to inform the patient that the donor's outcome of pregnancy will come from very healthy, below normal, to nearly like normal population. And National Kidney Foundation advises to wait for at least 6 months before allowing living donors to be pregnant. So take-home message, family planning is crucial. Baseline graft function and hypertension are very important. Prenatal planning for immunosuppression is mandatory. Meticulous nephrology, obstetric care is needed. Successful pregnancy, although of all these potential complications, is possible. And for the donor, pregnancy among living donors seem to carry the same risk as general population, although it increased from a better level at pre-donation stage. This is Mansoura City, and this is urology and nephrology. Thank you very much.
Thank you very much, Dr. Ahmed. So you mentioned also the outcome of pregnancy after donation. Thank you.
Time for one or two questions. هسأل سؤال بعد إذنك أحمد. احنا عندنا اوبزرفيشن العدد عندنا قليل في مستشفى المعادي، لكن بنحس ان كل الاوف سبرينج للفيميلز بيطلعوا بنات. فهل لاحظت التعدد عندك اكبر؟ هل شفت مثلا الفيميلز يعني 6 اوف سبرينج؟
الحقيقه ما خدش بالي منها عندنا، لكن ممكن نشوفها.
خطوه حلوه بس الليتشر ما قالتش كده.
انا مش متوقع ان في حاجه في الليتشر، انا مش متوقع، بس انا مش والعدد قليل عندنا، هو 10 اوفس يعني منهم واحده جابت 3 سكسسيف تشيلدرن وكلهم بنات. كويس، هو كويس بس اكسبلينيشن.
ما في ستات كتير ما لهاش غلط الموضوع ده وجابت 10 بنات ورا بعض.
يعني حضرتك عايز تقول الاميون سبريشن له علاقه يعني؟
هل الاميون سبريشن له علاقه؟ هل اظن كانوا بالصدفه الفيميلز؟ انا ما شفتش الميل اللي زرعوا برضه. فهل الميلز اللي زرعوا برضه جابوا بنات ولا لا؟ عشان يقول الاميون سبريشن له دور ولا لا؟ طب يعني بوينت لو نقدر نجمع اللوف سبيس.
بالنسبه للميلز يا احمد، تنصح بتغيير الاميون سبريشن او يعني المايكروفيوليتس
في كلام
قبلها بقد ايه؟
في كلام عن كده، لكن يعني بالنسبه يعني فاذرنج يعني كده ترانسميشن فاذرنج يعني الكلام برضه على الام ام اف والانتو مش واضح قوي زي
هو الام تور بس مش السلسبت في الفيميل.
لا والسلسبت برضه المايكروفيوليتس برضه
اهم الام تور
الام تور
سبرماتوجينيز
الام تور السلسبت في الراجل ما حدش قال في الفيميل معلش ريفايز يعني.
هو طبعا الام تور عشان اساسا تاثيره على الموضوع الفاذرنج يعني عليه ديبيت ويعني
كل الانتي بريمال دراجز جابوا سنه في الفيميل يوم الاذى.
لا الاذى لا
الميل،
لا الميل فاذر نوقف الام تور بس.
يا صح
الام تور هو الاكثر.
الام تور
يعني وقفوا قد ايه؟
شهرين او شهر ونص او شهرين قبلها
لحد ما يحصل بريجنسي.
السايكل سبرماتوجينيز 3 اشهر ف يعني او 4 اشهر، فلازم على الاقل قبلها ب4.
يعني هي لونجر عن شهر ونص.
انا ما لقيتش الحقيقه عليها وقت معين، لكن الانتور فعلا يعني في كلام عليها برضه، ما هوش 100%.
لا انا I have a reference going مع الدكتور صبري ان هو 6 months يبقى سيف. 6 months مش شورت بيريد.
لو وقف الانتور يبقى ريبليست بكالسينيورين يعني.
Yes.
بس الموضوع مش زي يعني انا قصدي اقول ده كلام برضه ديبيتبل، ستيل ديبيتبل، مش زي الفيميل. يعني موضوع توقيف الانتور او حتى يعني الانتور او الام ام اف